we are going to go ahead and get started with our crisis services panel. And I am just really delighted that the three of you are here today. All three of you represent important services that are basically emerging in Indiana, but also in our county. So I appreciate the three of you being here, what each of you are doing. The first speaker will be Chris Drapeau, if I said that correctly. He is Executive Director of Prevention, Suicide Prevention and Crisis Response for the Indiana Family and Social Services Administration for the state. And Chris will talk with us about 988 and the Indiana Crisis Response Network. He will be followed by Mountsier, who coordinates Oaklawn's mobile crisis response team. And finally, Kelli Liechty, who's Vice President of Access and Crisis Services at Oaklawn, will talk with us about the upcoming Crisis Stabilization Unit. We'll hold questions till the end, but we will flow from one speaker to the other. So Chris, we're going to go ahead and get started. Thank you for being here.
All right, hello everyone. I'm grateful to be with you in South Bend. I'm actually in the love of IU South Bend, so it's always great to come back to the area. And want to share some updates with you about what we're planning across the state in terms of crisis response. We know this is a really hot topic issue nationwide, but also throughout the state of Indiana, if you've been following what we've been doing over the past 2 years, when this federal legislation was signed into law by former President Donald Trump, the National Suicide Hotline Designation Act of 2020, which this isn't creating a new hotline. It's a hotline that's existed since the early 2000s, the National Suicide Prevention Lifeline. But what this legislation does is it shortens it from the 1-800-273-8255 number to 988. So it's a lot easier to remember, it rolls off the tongue a lot better, I think, that 10-digit number, but it also rebrands the National Suicide Prevention Lifeline. It's this image here, the 988 Suicide and Crisis Lifeline, because any of you who are familiar with this work, you know, you don't just talk to people who are thinking of ending their life. You talk to people who are facing a myriad of different types of crises that they may be experiencing, but it could be mental health, substance use, it could be just emotional distress. So this rebranding is trying to capture the fact that this lifeline does much more than just suicide prevention. And this is kind of captured here in some of the verbiage from SAMHSA, the federal government agency that is overseeing the Suicide and Crisis Lifeline. And just a heads up, if you ever hear of Vibrant Emotional Health, if you hear of this organization, they're administering 988 on behalf of SAMHSA, just in case you see them, wonder how they're linked with this whole system. But what we're trying to do, you know, in Indiana, 988 is so much more than just a lifeline. We're trying to leverage the momentum nationally and even in the state to revamp the entire crisis system and build a truly coordinated crisis response system, not just for St. Joseph County, but the entire state of Indiana. And so what House Bill 1468, this was signed into law by Governor Holcomb in April of 2021. What it did is that we were one of the first states in the country to have this 988 legislation put in place back in 2021. And what it did is it created this 988 trust fund so that future funds could go here and be only used for this crisis response system and nothing else. It also set up some expectations in terms of how a 988 center will be designated in the state of Indiana, and that the Division of Mental Health and Addiction will have oversight over this system statewide, and that includes the 988 centers, mobile crisis teams, and the crisis receiving and stabilization services. Now, another piece of legislation that you should know about, this was signed into law by Governor Holcomb in the spring of 2022. This updates who can serve on a mobile crisis team in the state of Indiana. And as you can see here, one of the things I want to point out to you is that there's some flexibility in who can serve on this team, but where we are not, where the General Assembly is not being flexible in terms of peer support professionals. A certified peer is a mandated member of the mobile crisis team, regardless of the composition. Whether it's a law enforcement co-responder model, or whether it's the traditional mental health professional, licensed mental health professional, or as you can see here, another behavioral health professional, or even if EMS or paramedicine teams are responding, there must be a certified peer that's part of that team. And also there's some flexibilities that this legislation added to the mobile crisis team, such as those who are supervising can do so via telehealth. They don't have to be on the scene. And so there may be updates to this in the future, but this is the current what currently is in statute for the requirements of mobile crisis response in Indiana. But as I mentioned, this is really what we're trying to do as a state, and we're grateful for the support from the General Assembly. But also, if you've heard, there was a mental health summit last Friday at the Indianapolis Convention Center that was really led by the Indiana Supreme Court. And we had Governor Holcomb was there, the senior leaders from the state Senate and the House of Representatives were there speaking. We had, Senator Kreider and also Chief Justice Rush from the Indiana Supreme Court. All of them were there speaking at the summit saying we must prioritize mental health in Indiana, and specifically this 90-day crisis system. When we started doing this in the fall of 2020, I never would have thought we'd be at this point where all three branches of state government up to the senior leaders are all saying the same thing in terms of we need to fund this and make sure it happens in the state of Indiana. So this really is, it feels different from times past in terms of mental health support. And we'll find out in this upcoming legislative session, if the General Assembly will, how they will fund this, because the magnitude of the funding will determine how closely we can reach this vision of making sure that everyone in the state of Indiana who's in crisis is someone to contact, someone to respond, and a safe place for help. And so the next session after this panel is with Rebekah Go of Faith in Indiana. They have been significant advocates for this crisis system work, not just in St. Joseph County, but across the state. So if you want to advocate to your legislator about backing this up, I recommend you connect with Faith in Indiana. As a state employee, I have to be impartial. I can't push approaches, but you can do more than I can. But you can talk to your legislator about what you think needs to happen. And what is our role at FSSA? It's that bottom part here. We're trying to align with best practices because we don't want to repeat the same mistakes that other states have made who have mature crisis systems that we're trying to develop here. So we're trying to start with a foundation of best practices and then innovate from there to truly meet the needs of people in our communities, because we know that what works in another state may need to be adapted here because we are a little different. We are more diverse than I think we get credit for in terms of the people that live in Indiana. But how will the state support this infrastructure moving forward? So this isn't just something we're excited about now and then it kind of fades away. How do we keep this enthusiasm going over time? So here's one way we're approaching this. For the 90-day centers, these are going to be statewide and centralized. And what we're doing is we're actually one of the first states to look at this type of infrastructure for these 90-day centers is we're aligning them all in the same telephony and software platforms. And I'm going to show you a slide next about, and we have five, to share this with you, we have 5 centers that are going to be part of this rollout. A Better Way Services in Mountsier, Indiana, who have been answering these calls for years. Mental Health America, Wabash Valley Region in Lafayette, and Crisis Center Incorporated in Gary, Indiana. There are 3 active centers that have been doing this work for some time. We have 2 additional centers that are coming on board. One is Remedy Live, who will be our primary chat text vendor for 90-day. Currently, we're advertising 90-day calls, and we hope to be up to 100% capacity for chat and text by July of 2023, just a heads up. And the other organization that will be joining us as a 90-day center very shortly is Mental Health America of Indiana, and they're based in Indianapolis. So all of these centers will be linked on the same platform, and we'll be answering calls, chat, and text messages statewide. And so we hope that by doing this, we can standardize what is offered to people in crisis, because people in crisis need predictable services. We have to ensure that they're getting the same service no matter who answers the call, chat, or text message. And then also ensuring that by having them on this state system, each time someone reaches out, they'll go to the next available person at one of these centers to try to speed up the response and make it more efficient. The good news is we've come a long way in Indiana. Just back in 2019, our instant answer rate was around 52%. As of last month, it's 82%. So we're doing great, and we found funding support for our centers so they can move away from all volunteers to fully paid staff. So there are some historic changes happening within our 90-day centers alone that we're very excited about. But this is the next step. We're asking them to be much more than just the centers that are answering calls, chat, and text messages. We're trying to set up so they function as air traffic controllers, or as you can see here, air traffic control. So they're helping people in crisis navigate through the entire system. The purpose of this is to make it easier for people in crisis to get connected to the resources they need and not place the burden entirely on them. This is a system that's about action and ensuring that people don't fall through the cracks. Now, we're not going to get it right in the beginning. There's a lot of kinks we have to work through as we try to figure out how to work together across the state. But this is the vision. This is the future we're heading toward. And so these 988 centers will be able to centrally dispatch mobile crisis teams across the state once the software is ready. We're hoping it'll be in Q1 of 2023. But they'll also be able to schedule outpatient appointments 24/7. They'll have access to registries to see which of our crisis stabilization units across the state have available short-term beds and observation chairs. And there might be ways to look at how we can link with all the creative resources that exist in our community. Because one thing that we've been very clear about is that you can't have a one-size-fits-all approach for a person in crisis. Because some people will need outpatient therapy, but others, I sat in on the youth panel, and some of the services that were being provided by the folks up here, how can they be connected into the system so that we can route people to the right support at the right time? Because people are unique in terms of what drives them to a crisis. We have to meet them where they are. We also need to be held accountable. So we want to create public-facing dashboards so you can see how we're doing on these key metrics. And of course, we also need to understand how to measure trust. Because at the end of the day, if the public doesn't trust the system, they're not going to reach out to it. And then what's the point of what we're doing? This is all for the public. So we need to make sure that the system is continually focused on them and their needs. We have a number of mobile crisis teams that exist throughout the state already. You'll hear about one of them today here in St. Joseph County. And a lot of these are being funded by disparate funding streams. So as communities are learning how to do mobile crisis teams, we're hoping that 90-day will help coordinate these efforts across the state. Because what we're seeing is there's a lot of enthusiasm for this, and people are just like, I'm going to start a mobile crisis team. Well, have you talked to this other team that's already doing that? No. Well, you probably should do that. So you're not, we're trying to avoid turf wars and miscommunication. So we're hoping that 90-day can help coordinate this if they provide centralized dispatch. So we're truly working together as a community. And as Kelli will be sharing more about crisis receiving and stabilization services, this is something we want to make sure people across the state have access to. If the 988 center or the mobile crisis team can't stabilize the crisis, they have another option besides going to the ER or going to jail. That's why this system is so pivotal. And I'll share a slide soon that shows the return on investments that other states have seen so far. But notice that we didn't say a safe place to go. We said a safe place for help. And the reason is because the youth crisis response will look different from adults. Right now, we're really focused on adults, but we're going to be looking at something called Mobile Response and Stabilization Services Model, or MRSS, specifically for youth and family crisis response. And there are a number of states who have used this model and have become experts in it. One example is the state of New Jersey. Ohio and Illinois are also looking at this model, because what we want to do is make sure that when we respond to youth in crisis, we're stabilizing their crises where they are, and we're not separating them from their family or their guardians. So we're trying to keep them in their placements and not taking them to something like crisis stabilization center unless it's absolutely necessary. So making sure that families remain together. And the state of New Jersey, they have this just unbelievable statistic where they found that 98% of youth that receive MRSS services remain in their current placements, even foster kids. And so they've had tremendous success in terms of seeing a good return on investment from this model. And I think it's notable that the state of New Jersey typically has one of the lowest suicide rates in the country every single year. Don't know if it's because of this model, but perhaps it might be a contributor. This is just some information there that'll be coming in the future. But the system we've been talking about, this is from the southern region of Arizona's crisis system from 2019. As you can see, the majority of people who interface with this system, their crises are stabilized. And if you see at the very end, 85% remain stable in community-based care when they do follow-up. But one of the key aspects of the system is making sure that we're providing just crisis care. And if you look right here, you see decreased use of jail, of prisons, of emergency rooms, and inpatient units, very costly and restrictive interventions. So what you see when you implement this model is it saves everyone a lot of money. And it also allows law enforcement to focus more on public safety and less on being the primary responders to a mental health crisis. So this is what the system has been shown to do in other states, and why we believe so strongly in it here, is we're trying to meet people where they are. And as it says here at the bottom, find the least restrictive and least costly way of supporting people in crisis. This is our vision and mission statement for 988. We want to make sure that every Hoosier has access to quick, competent, and nation-leading crisis response services. And we believe that I would make this argument here, the best model for crisis response that exists, let me go to that slide really quick, is a trauma-informed approach. If we become experts in aligning our crisis response with this approach, I think we'll be very happy with the outcomes. Because I hear from people across the state that they don't have a voice. When they reach out, they're afraid of what's going to happen to them. There's across the country already, people are saying, don't call 988 because you won't be happy with the response. And I've encouraged my team, let's embrace that feedback because people have fears. We need to listen to those fears. We need to think about how we're going to respond to those thoughtfully. So how are we going to collaborate with law enforcement if people are afraid of a law enforcement response? How can they be clear about what will happen when they reach out to 988? And that's on us to make transparent. I just want you to hear that our team is interested in doing that so nobody's surprised when they reach out to 988. I know that's a tall order, but it is on our mind. Now going back, I think it's important to remember that the primary goal of crisis intervention isn't necessarily to direct someone to a specific outcome, but it's to restore a feeling of control in the lives of people who feel like the ground underneath them is falling apart. And this is something, so I'm a licensed psychologist as well, and this is something I have to remind myself when I'm seeing clients, is you get that feeling when you know, I think this person's thinking of suicide, but they're not telling me. And sometimes it brings some anxiety as a clinician because you don't want them to die by suicide. But sometimes we get deceived by this saving other people, and we forget about how to empower them. And so I've heard people say, or my guts told me like, hey, this person's probably thinking of suicide, but they keep saying no when I ask about it. And then when I open up and say, look, if you tell me you're thinking of suicide, this is how I approach it. I'm not just going to send you to the hospital because you say yes. I want to come up with a plan with you to keep you safe. And it's no surprise after I lay that out and I build trust with them, all of a sudden they open up and say, yep, I've been thinking about it. And I've been afraid of telling you for these reasons. And so what I've learned, at least anecdotally, what I've learned is that if any of us carries authority that can impact another person's autonomy, they're going to be hesitant to open up. And that's just not licensed providers, it's law enforcement as well. So we have to be very thoughtful of the power dynamics at play when we respond to people in crisis. And that is why peer support professionals must be a part of this system. Because peers have lived experience, they've been in crisis before. They know what the system, navigating the system is like. And if you look at this here on the common themes and the elevated stress response, this is typically themes that activate the human stress response based on the current research literature. Now, if you could think about a law enforcement officer responding to a crisis, can you see these themes being activated? If the person is unsure if they can trust that response, or even a licensed provider. But if you look at this, I'm mapping it up with the trauma-informed approach and peer support. See, peers typically don't have the authority to take away someone's autonomy, but they can connect with them on a level that other professionals cannot. And so that's why it's imperative that peers are a mandated part of the system, not just for mobile crisis response, but crisis stabilization, every part of the continuum. It allows a level of connection that they just might not be able to get, the person in crisis may not be able to get elsewhere. Now let me go back here. I want to make sure I didn't miss a slide. There we go. So we currently have some planning committees statewide, and some of these are going to have to wrap up, but I'll be clear, the two committees that likely will continue to live on are the 988 equity committees and also 988 and 911. We're currently doing a lot of relationship building with our 911 centers because there is concern about, well, how are we going to work together? When do we divert to 911? When does 911 divert to 988? So we're working through that and figuring out how to create decision trees. But equity is work that must never stop because we need to figure out what are the unique needs of people in our communities and how can we meet them? And that's not something you can do in a few months. So we have a 90-day equity consultant who is leading those efforts, and she's going to start focus groups. But if you have efforts locally that you would like us to align with in terms of figuring out how to do equitable crisis response, we would love to hear from you and see how we can align and work together. Some of these other committees will have to wrap up soon, but those two at least will continue on. So I think I got a few more minutes here. Oh, good. So I just have I think 2 more slides. Yeah. So one thing to bring to mind that I want you to know about, if you're thinking about contacting your legislator, I want you to know about this opportunity for states in the US. What that federal legislation allowed is for states to look at the opportunity to enact a 988 surcharge or fee on phone lines, similar to what 911 does, to fund the entire crisis system. Or as you can see here, anything in the crisis system that touches 988 could be funded through such a surcharge. So I know Faith in Indiana has made this clear. And if you want to be a part of advocating for this, if you so choose, I have to be neutral. But if you want to take advantage of this, you can link up with local groups and talk to your legislator about it. And finally, what are we doing? We've invested more than $50 million so far in the 90-day system, but it's all federal. Kind of scary because eventually it's going to run out. So we need support from the General Assembly if we're truly going to build this and sustain it, because everything we're sustaining it with currently is federal funding. And we're also looking at how Medicaid can reimburse not just mobile crisis and crisis stabilization services, but also the 90-day line. There are ways to do that, so we're exploring that, but it takes months. It takes a long time. So these are the different funding streams that we're utilizing so far. There are some Medicaid dollars currently. SAMHSA block grant dollars. It's a federal agency that gives funding to all U.S. states for specific purposes like addressing people with serious mental illness. Discretionary grant fundings that we receive from the federal government and also private corporations like Vibrant Emotional Health. They're actually a nonprofit, but it's considered a private grant. I don't know why, but just that way. American Rescue Plan Act funds, which you might have seen locally for some of your crisis efforts. We've been able to use the home and community-based funds to put a lot of funding into our 90-day centers. That's where the bulk of their funding comes from right now. Medicare and commercial insurance are big question marks. We don't know how they're going to be involved, and we don't know if it's going to take legislation to get them involved. But if you have connections there, I strongly encourage you to explore that. We are trying to as well. And that's all I have, so I'll go ahead and turn it over to Ricky.
All right, so thank you, Chris. That was amazing. I just want to touch on something real quick that you mentioned that I fully believe in. So, my name is Mountsier. I'm the coordinator for the mobile crisis response team at Oaklawn, and I'm a peer recovery coach. That's my credential. So I certainly appreciate the state legislature putting in that piece about peers involved with mobile crisis. I think it's important. It's the lens I approach things with. So I appreciate that. Thank you. So to get started, before we kind of go into things, I just want to get us all in a little bit of a mindset about mobile crisis response. So let's just talk a little bit about a kind of a case example or a case study and kind of a scenario to get us going. So we see a man who is maybe noticeably disheveled and talking to himself, possibly responding to some internal stimuli, and he's near a busy shopping area. He's on a sidewalk. He's not confronting anyone, he's keeping to himself. Passers-by, people in the area notice that he's having some struggles, he's having some difficulties. Again, he's not harming anybody, he's not, acting out towards anyone. A natural response for a lot of people would be to call law enforcement, say, hey, this person needs help, let's get him out of here, and so be it. They say, hey, he's well within his rights. He's on the sidewalk, he's not harming anybody, he's not doing anything to make us intervene at all. Another response may be to call EMS. EMS says, hey, he's not experiencing a medical emergency. We have no need to take him to the hospital. So what do we do? Well, another approach could be to call a mobile crisis team. So this team could, receive a referral from 911 dispatch. It could receive a referral from law enforcement, possibly from EMS, from business owners or other community members. And what the team can do is they can come out and work to build rapport with him and maybe get him connected to some appropriate services to help meet his needs, help remove barriers to those services to help meet his needs. And this is a very sort of like reductive, scenario. A lot of times what we see with mobile crisis is that it is more complex than that. But I think this kind of gets us thinking that, what do we want a response to look like? What can we do? How can we incorporate this into our community? So from this, what we know is that emergencies and crises, both physical and mental health, originate in community. I think that's clear. I think we could all probably agree on that. And to address those emergencies, we need this systemic response because these emergencies fall on a huge spectrum. The standard of calling law enforcement, calling EMS, that we've been doing that, and we need to further take, action to address the wide range of emergencies and crises that happen. So by incorporating mobile crisis into the community, we can work to build trust with those individuals in crisis and help kind of ally with them and support them and get them connected to those appropriate, resources and resolve the crisis. So with that, our mobile crisis team, we've got some goals that we try to kind of think about. The first one is to provide crisis services in natural environments. So that would be going out to somebody in the community, meeting with them in their home, possibly going to someone's place of employment if that's necessary, working with other community partners, maybe some shelters, maybe some drop-in centers, things like that. Primary care offices as well. And we want to provide services to difficult to reach populations. So that would be maybe individuals with serious and persistent mental illnesses, individuals who are hesitant to engage with some of these resources in community. So if we can actually go to them and help build that rapport and build that trust so that they can kind of increase their motivation to engaging in those services, then we can reduce the utilization of hospital, law enforcement, EMS, those kind of things that we see that are utilized so frequently. And again, we want to reduce the utilization of hospitalization by helping build that motivation to use these other resources in the community. We talked about community a lot today in the youth panel and earlier at our keynote. Mobile crisis is another angle of that. And then providing appropriate care and support while avoiding unnecessary law enforcement involvement is another goal of mobile crisis. And Chris touched on that a little bit earlier with the whole 988 crisis continuum of care. So when we were developing the mobile crisis team at Oaklawn, we were doing a lot of research, looking into a lot of things, and looking at what other communities were doing, looking at what was out there. And this is a quote that kind of stuck out to me. So for people experiencing crisis, community-based alternatives that treat the unique experience of the client as something to work with rather than against have greater capacities to support personal learning, healing, and growth. And I think that sums up a lot of what we've been talking about today, meeting people where they're at, really creating these individualized paths to get people connected to care and really connected to the community as best we can. So what does our mobile crisis team look like? So right now, we have 2 master's level clinical staff, 3 peer recovery coaches, 1 case manager. Now, our case manager is part-time with us. She splits time between our mobile crisis team and our intensive case management team. What we saw was that after we worked with individuals for a period of time and they were able to get engaged in services at Oaklawn, a lot of those individuals were getting referred to our intensive case management team. So we really wanted somebody that could kind of bridge between those 2 teams. And we found that this works really well. She goes to all of their staffing meetings. She knows the clients already before they start services with the intensive case management team. So there's already kind of a natural connection, and it's been working really well so far. We really like this approach. Currently, we are able to provide phone support 24/7 to individuals in St. Joseph and Elkhart County, and we're able to mobilize to adults Monday through Friday from 8 a.m. to 5 p.m. in St. Joseph County. Now, I'll be talking about some of our efforts to expand that here a little bit later on, but currently right now, as of today, this is kind of how things stand. So now that we know a little bit about the team and kind of what our makeup looks like, what's our process? Well, if somebody is in crisis, they can certainly call Oaklawn at our main line, 574-283-1234. When you call that line, you get an automated voice message that says something like, thank you for calling Oaklawn. If you know your party's extension, you may dial it now. If you're experiencing a mental health emergency, press 1. So you would press 1. And we also get referrals sometimes from our switchboard operators, our access center staff, and some of the other administrative support professionals that we have, at the organization. Calls come to them, and they feel that it needs to be escalated to our team, so they'll transfer it over to us. So from there, the mobile crisis team will answer the call and begin our triage process. So during that triage process, we're really looking to gather information to give an appropriate risk rating so that we can, make an appropriate response to the situation. So really, we're looking for what's the reason for the call? Why is this person calling? What's going on? What are the precipitating factors behind that? What has changed? What have been the situation changes here? What do their social supports look like? Do they have those kind of natural supports that we can lean into to help them navigate that crisis? What's their functioning level? Are they maybe experiencing some visual or auditory hallucinations? Are they having delusions? Are they severely impaired due to substance use? What's going on? What are environmental considerations that we need to look at? Are they at home? Are they on the street? Are they at their work? Are they in a non-supportive environment? Are they with people who are not being very supportive of them? And we need to help kind of get them to connected to an environment that might be better. So from there, we also have the ability to incorporate some screening tools such as the Columbia Suicide Severity Risk Scale, the Cage Aid, which is a substance use screener, and an opioid overdose risk assessment tool. Once we go through all that process and we determine what risk level they're at, we can act accordingly or apply an appropriate intervention. So we do always get the option to mobilize to the location whenever whenever they're in St. Joseph County. But a lot of people just want to call and they just want phone support. They don't necessarily feel comfortable with us coming out right away. So in that case, we will provide phone support and help kind of set up next steps for treatment or connection to resources or referrals or whatever it is that we can do to help. Some callers wish to come into the office and say, hey, you know what, I live right around the corner. I'm just going to come in with you guys right now. Okay, cool, great. If a mobilization is necessary, so if it is determined that we do go out and do meet with the individual, we do ask some safety questions just to reduce the risk of harm to the person and to us. We want to make sure safety is priority. So we want to make sure that everybody is safe and that we can help get that person connected as best possible. So when we do mobilize, we always mobilize in a team of 2. And this is actually recommended by SAMHSA as one of their best practices for crisis response teams. And that mobilization may be 2 of our clinical staff, it may be 2 of our peer staff, it may be a combination of both. I really like when we're able to take that sort of interdisciplinary approach, have a clinical staff and a peer support. We can kind of come at things from a few different angles and a few different lenses and really best support that individual. But due to staffing constraints at times, sometimes we do send out 2 peers, sometimes we do send out 2 clinical staff. It just kind of depends on who's available at that time. So when the team arrives to the location, they always notify the supervisor that they've arrived just to make sure everything's good. Hey, we arrived, we're about to go in. And then after that, we always do a check-in 30 minutes, post arrival. And this is just to say, hey, we're still good, we're still working on it, we're going to be a little while longer, or hey, we're about to head back, or whatever's going on right then. We found that really communication and coordination with the team has been key. We like to kind of keep each other on the same page, make sure we all know where we're at, because there's a lot of moving parts when an individual is in crisis. So after that, after we get the crisis resolved, and however that may be, we do always try to provide follow-up as best possible. Sometimes we do run into challenges. The individual may not have a phone. They may be, unhoused. It may be difficult to locate them the next day, but we do try to follow up as best as possible and continue to help link to appropriate services and resources. And then we will continue to try to engage with them until they basically tell us no, or we can get them kind of connected to ex providers or whatever, community partner that is appropriate for them. So as far as some next steps, we recently began taking direct referrals from our 911 dispatch center on October 3rd. And actually, we just had a meeting yesterday to kind of review how things have been going and tweak some things a little bit. So that's been a really exciting step that we've taken here over the last month. As of beginning on Monday, we are expanding the hours from 8 a.m. to 8 p.m. So we're pushing out a little bit into the evening. And that's been another big task for us that we've really been looking forward to. So I'm happy that we're able to accomplish that starting on Monday. And then we do have a goal to move to 24/7 support by spring of 2023. Now, to do this, still really need to hire and continue to train staff. So that's been a challenge, as I'm sure many of you are aware, working in this field or associated with this field. Staffing is always an issue. So we're still working at that. But then we also want to continue to develop those relationships with community partners to support those individuals in crisis. So really kind of building that network, really increasing our community capacity so that we can get people connected to the appropriate resources whenever necessary. That's all I have. There's, again, if somebody is in crisis, they call Oaklawn at our main line and select option 1. Certainly feel free to reach out to me if you have any questions. That's my direct extension, also my email address. I would say if you're with somebody in crisis, it may not be best to call me. I'm not always able to answer my phone, so I would still recommend calling the main crisis line. So Thank you very much, and we'll go to Kelli.
All right, there. Oh, man. Whew. Good morning, all. It's really good to be with you. My name is Kelli, and I'm the Vice President of Access and Crisis Services at Oaklawn. And I really enjoyed both of the presentations as well. I just got back last night from Bloomington, where we spent 2 days with individuals all over the state talking about crisis services and the crisis continuum of care in Indiana. And so I come to you energized with that new knowledge. I think Chris did a great job of just providing the overall framework of where we are and really alluding to the point that the attention is on us right now, and there's a real opportunity in that. I think I heard that across the board, that there is agreement and alignment that we've got to do better in the state of Indiana, and there are smart, focused, dedicated individuals working on that. And that is exciting. We have such a great opportunity. And so I'm excited to share with you a little bit about that today. One of the pieces of the 2-day meeting was we had individuals from Kansas and Missouri come and speak. Their states are a little bit further ahead than we are in Indiana, where they have fully implemented crisis response teams that are sustainably funded in their states. So it was great to hear from them, hear how they got there, and learn from their best practices. And I also just felt like it is us Midwesterners' time to shine. Like, when do you have like Indiana and Kansas and Missouri like leading these innovative efforts? So I don't know what that's about, but that's exciting, and I'm happy to be a part of it. So as we talk about the Stabilization Center, this is an emerging center that we are working towards in St. Joseph County. So as I talk, this is very much in process. We are learning, we are developing, and we are planning. So there will be a lack of details, and that's intentional, as we don't know those yet. So that is where we are, and I'll just be transparent about that and give you the information that we have and let you know sort of when we'll know more information. So the Stabilization Center is that piece, like Chris alluded to, of a safe place to go. So we are developing a 24/7, 365-day center that is focused on the treatment of individuals who are experiencing a crisis, where we can work to de-escalate and reduce the acute symptoms that they're experiencing. And you'll talk about these centers as importance of being no wrong door. This is come. We'll take you and we will help you. So that's sort of the attitude and philosophy behind this. As we have planned for this and talked about this, we have talked about the continuum of service delivery. I talked about earlier on the adult panel, our open access process. We knew that to have important crisis response centers, we needed to do better first at having low barrier access to outpatient care. So that's what we have done first. We have opened up open access at Oaklawn, where we have low barrier access to care. You can walk into our campuses any day of the week during blocks and be seen by a therapist. And we know that's important to prevent crises, as well as, like Ricky said, when someone's in a crisis, for them to be able to say, hey, you can come back tomorrow, and we'll get you into services. We'll get you on that intensive case management team or in one of our intensive groups. And so that's what we think about for open access. And then as we talk about this 988 mobile response stabilization centers, those are for individuals experiencing higher intensity of symptoms. And we need stops all along the way for this to be effective and to have people treated in the place where they need to be treated. As we think about this a little bit, I think it's important to maybe just put a picture a little bit to who is appropriate for what type of service, right? So on the bottom, we have people with their symptoms may be mild to moderate. Daily activities are a struggle without treatment. They may worsen. They're able to tolerate a waiting room. They're seeking services. That's our open access. That's come in, let's engage in outpatient treatment. And as we think of The stabilization center is for those people who are experiencing more moderate to severe symptoms. Daily activities are a struggle and some just aren't even being met. There's a concern of risk for themselves or others. Okay, so I think when we think about this as providers, we've all had that person where, like Chris said, they come in, we've worked with them, and maybe we're really identifying they need a higher level of care. And so what do? We send them to their emergency department, or we try to get them into inpatient, and we've all heard, well, they're not bad enough, they're not sick enough. That is a horrible feeling. And we face that a lot, right? And hospitals are, like all of us, dealing with short staffage, and so we're all doing the best that we can right now. So this is going to fill that gap for those people who they're not there, but they don't need outpatient, they need something more severe, then they'll come to our center. Just a little bit of background of sort of where the vision for this came. There was a group of individuals meeting in St. Joseph County. Rebekah from Faith in Indiana was on it. That was from our Tyros meeting. So these were trauma-informed recovery systems of care meetings. So they were stakeholders from our community that have been meeting for over a year, doing mapping of our community to figure out where are gaps in services, where are individuals ending up in hospitals or jails because we have a gap in services. We're not able to meet that need. And this was an engaged community effort. We had individuals from law enforcement, the sheriff, individuals from jail, consumers, clients, hospital systems, the public health department. This truly was a community effort coming together, brainstorming about what was needed and coming up with this idea. So they identified through their modeling of our community, from their conversations, from listening to families who needed care and weren't able to get it, that they needed a hub. That's kind of what they developed. That we need a hub in this community. We need some place for people to go and to be seen. And so that work had already been being done when 988, was announced and came about. So it was really beautiful timing that this community effort had already been happening, and there was already support from the community, excitement from the community, and so we've been able to just walk into that, and it's been great. Both Chris and Ricky already spoke to some of this, but when we think about crisis goals, it's about treating individuals in the least restrictive environment that meets the need, screening and moving highest risk patients to a safer environment if that's needed, beginning treatment as quickly as possible, to minimize the overutilization of emergency departments and law enforcement. This is our chance to take a stand and say, well, we're going to step into these crises and we are going to engage and we are going to treat. We have far too long relied on emergency departments and law enforcement to respond to those. We want to reduce unnecessary or redundant tasks. And I think all of this is grounded in creating the experience we want for our family. And so thinking about that, how do we create a trauma-informed environment where we would want our loved ones to go to and know that they were going to be taken care of. This is currently where we are. This really continues to be a community-driven effort in terms of both the planning and the funding. The funding is coming from several different sources. We have some SAMHSA grant funds that we will use. We have some of the COVID funding that came about. We've applied for other grants. The city has given some money. So we have funding right now in the form of grants. And we are also working actively at the state level, like Chris said, to push for a sustainable funding source for this. We know that these services are needed and beneficial, and so we are working collaboratively for a sustainable model. Beacon are certainly our partners in this. We are working alongside them, and we have a space that will be housed right next to Epworth. In that building there. So we are finalizing the architectural drawings. I believe they're done as of this week. So Monday, we are going to do a walkthrough of the space. They've taped it down for us to see, what's going to be. So we're going to walk through that space and then working to finalize the budget and staffing models. I didn't put a firm opening because so much is up in the air right now with construction. So once we get the architectural plans and we'll bid it out to contractors, that will largely dictate the timing of this when they're able to come into this space. But we do have the space. It's a beautiful space. It's on the ground level. I think it'll work really, really well. The staffing model will have a multidisciplinary team of nurse practitioners, nurses, social workers, case managers, and of course, as we heard about, that foundation of peer recovery coaches. Some of the treatment that they'll be doing risk assessments and safety plans, working to stabilize, de-escalate, discharge planning, start of medication. We'll have nurse practitioners there that can do assessments and start medication, or maybe this individual has had a lapse in medication, so what can we do to get them back on that? And then of course, this link to ongoing treatment and services will be key for this center. It will be a walk-in or voluntary center. So this will not be a place where people will be on any sort of papers or brought in an involuntary way. This is a voluntary walk-in center. Those who need medical attention as their primary will still be diverted to the emergency department, including individuals who are in active withdrawal and need that medical treatment. We are going to have a specific drop-off entrance for law enforcement in the back. So we are partners in this, and we want to make it as easy as possible for law enforcement to be able to bring some in, and for us to be able to reduce stigma and accept that person. There will be recliners, and there'll be an observation model. That's what we know now.
So much to the three of you, and we have a lot of time for questions. So if there's anybody who would like to ask questions, and we'll have Rebekah come up, who's been referenced multiple times after we allow some time for questions for this panel. So does anybody have anything they would like to ask any of our panelists? Yes, in the back.
Kelli, will that center that you're in the works on, will that be?
Okay, it will be housed in St. Joe. We will not be turning away people from other counties that come.
So police from Elkhart County could potentially.
I'll have to look into that. I'm not sure how that will work with jurisdiction with law enforcement. Yeah, that's a great question.
Anybody else? Pink, yes.
So this is super exciting. I was wondering, so in terms of the 988 structure and the crisis mobilization structure, is there the entry into 988 can be referred to from another, like, do you guys talk to each other in the strategic planning? I guess is ultimately the question, right? So in terms of like 988 referring to different lines in crisis response and crisis response being able to plug into 988, is that a coordinated conversation?
Yeah, it's a great question. So because we had a federal mandate of being ready for the launch of 988 by July 16th of 2022, and because we had specific Indiana statute that said we had to meet certain expectations from the General Assembly by July 1st, 2022, we've been really hyper-focused on just building up capacity for the 988 centers, because there was an anticipation we were going to see this huge volume increase, which actually we haven't seen a large increase. We've seen a somewhat of an increase, but not as large as a lot of people expected. But to get to your question, we are looking to coordinate with mobile crisis teams, especially in terms of determining how we triage, not just the 988 centers, but law enforcement across the state. Because we can tell you, like Indiana State Police, Indiana Sheriff's Association, they are fully on board with this crisis system and diverting away from law enforcement. And so I think we need to also think about how can we be better partners, which Oaklawn, they've already been doing this locally. So at some point, we need to bring everyone together to have a conversation about how we can link the two. The reason why we haven't is because the software that will allow the 988 centers to centrally dispatch, we're not expecting it to be ready until Q1 of 2023, so anytime between January and April. So we're currently in the contracting process with our software vendor, which is Bamboo Health. So that we've been really focused on just getting the 988 side standardized and stood up or expanded. But I agree that we need to also talk to our mobile teams about how to coordinate more closely. But I'm stuttering a little bit because there are so many funding sources that are funding these mobile teams. So we have some that are funded through what's called the CCVAC grant from SAMHSA. We also did a RFP where we're funding 4 mobile crisis pilots to try to they're kind of the first, I guess, the guinea pigs to test with coordinating with this 98 system. So that's why I'm like, well, how much can I tell you? Because there's all this stuff going on. And we do need to have a more coordinated discussion at some point.
And then I have a follow-up, and it's related to like funding streams and stuff like that. I'm so heartened by all of the work that's going on. But from like, if everybody, I guess it's the fun, to stabilize programs, there needs to be stable funding, right? And so like from a collaboration perspective, right? If anybody knows anybody at the city locally, because I don't think, you know what I mean? Like how do we work with our legislators? How do we present, you know what I mean? Like what data is needed so that so many of these incredible systems don't need to be grant funded anymore, but can be funded by the institutions and the structures that say they want, right? Like workforce development, economic productivity, workforce stability, right? Like all of those things come out of mental, family, individual wellness. And yet it feels like it's often really hard to engage those sectors in providing that stable funding that so many.
She's itching.
I'll say, Rebekah, I just want to mention one thing. One resource that could be useful, that could save you some time, is if you've seen the Behavioral Health Commission report that was recently released. There's a collaboration happening between 3 particular nonprofits in the state: the Indiana Council of Community Mental Health Centers, Mental Health America of Indiana, and NAMI Indiana. They put together a toolkit to promote the Behavioral Health Commission report, and there's specific guidance for the General Assembly in terms of funding the crisis system. So I would say start there. And if you have any other questions, you're always welcome to reach out to me. We can try to get you more information if that'd be helpful. Yeah, sorry, Rebekah. Is that it?
Yeah.
Okay.
I would also say there is a lot happening at the state level that could provide sustainable funding. So that was part of the 2 days in Bloomington. You'll hear this movement, I hear the CCBHC movement, so the movement for the state to transform community mental health centers to certified behavioral health clinics. So there are states that already have this model. And what's key about that model is it Medicaid, there's different options, but they'll pay for crisis services in a way that's not happening right now. So right now, the crisis work that we do at Oaklawn is grant funded. Other states, Kansas, Missouri, those programs are funded long-term. And so that's where we're headed. So they have a proposal that they're submitting, DMHA, November 1, to the legislators that they'll look at for the sustainable funding for this crisis center.
Yeah, I mean, it's just the report going to the General Assembly is just kind of a plan of how we could approach CCBHC. The funding piece is going to take a long time. So that's why I want to this is the legislative session. If we're really going to do something big in funding mental health, like this is it. I've never seen anything aligned like this before, so this is our chance. It's okay for me to say as a state government employee, but I think that Behavioral Health Commission report is what you go with right now, because Medicaid, oh yeah, we're looking under every rock that we can to sustain the system, but Medicaid is going to take a while. That's a months long process to even get it right on the state side, and then we have to get approval from the feds. So that takes a while. So I just want to kind of level set. We can't rely on Medicaid immediately. It's going to take some time to get that going, but we're definitely on board with figuring out how it can sustain the system. It's just one piece. Yeah.
Yes, so you mentioned that it was going to be in Epworth building. Are you guys going to be partnering with Epworth then? So I guess I can imagine some people have took to Epworth that they probably actually would have benefited from just a 24-hour stay, but there isn't really anything. So then I know some people are like, I'll do anything but get locked up. To them, it's a trauma. So are you guys partnering with them? Like say maybe they're past what needs to be provided, they can get entry there, or try this first and then Epworth? Is there like a great?
Yeah, we are certainly partnering with Beacon in this effort, so it will be jointly staffed. And as we are planning and meeting, we are planning this together. But I think it goes back to some of those goals of crisis work to treat in the least restrictive environment. So I think for those individuals, absolutely, we would want to, treat them there, see, be that stabilizing place. And then if needed, we can look into other avenues of increasing the level of intensity. But yeah, again, this will be walk-in, voluntary, so, a different feel for sure from the inpatient side. Yeah.
Jen?
I have a two-part question. Sorry. One is, I just want to say thank you guys so much for getting this going. Our community definitely needs more assistance with mental health services. And this is really encouraging to hear all these steps that are happening. I have two questions, mostly regarding to the hub. One is, I'm hoping that maybe in the long plan, there can be more collaboration between the psychiatric nurse practitioners and then the ongoing family practice, internal medicine doctors that are going to be prescribing those medications long term. Sometimes there's there's a difference in profession and professional comfort with being able to prescribe those medications. And as we're looking at a longer term option for patients, I'm hoping that maybe there's collaboration with that in the future. My second question is actually for each one of you, what is going to be the marketing for all of these wonderful resources that you have? As I look around the room, there's a lot of frontline people that are in here, but this is information that needs to get to every single person within this area. Is there going to be any plan of getting this information out to everyone within our area?
So for statewide, we have purposely held up on marketing 988 because we didn't want to inundate the centers before they expanded capacity to respond. And so actually we're hearing from our centers that we need more volume because we're expanding capacity, so we're ready. So our the Family and Social Services Administration, our communications team is looking at, it's going to find a vendor that can help us with marketing 988. And we're going to try to secure funding so we can do that continually into the future. So from the state side, that will be coming at least for 988. I'm not sure how we're going to link in mobile and crisis stabilization across the state, but at least that's coming down the road at some point for 988 marketing. But that's why we've held off to this point, just to make sure they can respond to increases.
Yeah, and I'll say from the mobile crisis perspective, when we started this, we only had, it was like myself and one other person for a while. So we were, again, it was a capacity issue. We were kind of keeping things not quiet, but kind of tiptoeing in as we staffed up, and we're still continuing to staff up. But now that we're expanding a little bit more, I have worked with our marketing team at Oaklawn. They've started to develop some things to get some stuff out from the Oaklawn perspective. So we are starting to make some efforts to kind of get this out a little bit more broadly. So just again, with mobile crisis, it's been a capacity issue, but now that we are expanding a little bit more, we are working towards that.
And I think to your first question, we've talked about that a lot internally, and I think there is a real need for that. And so some of the things we've talked about is, if we start someone on medication at Oaklawn, right, because there is a shortage of psychiatrists, and so how can we collaborate better with primary care individuals? So what does that look like? Does that look like us providing some staffing then, or some consultative hours where we're starting a medication, and then every Monday we have a psychiatrist and individual, PCPs or people from the community can call in to sort of talk through cases, get that kind of how do we expand the knowledge and comfort so that there is more treatment available. So yeah, great point.
Jen is raising her hand again, but then the person in front of Jen has a question.
It's not a question, it's a statement. I know that this is crisis and we're all here, actually as our own firefighters in the mental health world. I'm hoping that maybe in 5 years we can all meet together to look at the steps before crisis of getting more services in our area to be able to help people.
The person in front there again.
Yeah, I just had a quick question for Liechty. So I work for our local health department, collaborate a lot with our suicide prevention and get calls, conferences, and so on. And I think now I have a little bit more questions and answers on 988, which I'm sure a lot of people do. But it sounds to me like it's veering more towards like a 900 center for mental health concerns, rather than being able to call and talk to a crisis counselor about maybe some concerns they might be having about the suicidal ideation. But it sounds a little bit more like that. So would you recommend that I would say crisis texting or might be a better option
So that's not going to change in terms of what 988 has been providing. So you can still talk to, we're calling them crisis specialists because they're usually not licensed counselors, and Indiana statute defines a counselor in certain ways. That's, if you see crisis specialists, that's why naturally they say crisis counselors. But that's not going to change. So you can still call and talk to someone. It's not going to be like quick, like we gotta get you in and out of this call, chat, or text message. But the opportunity that's being provided is that if they want something more, they want somebody to come see them, a mobile crisis team can be dispatched if they desire that. So that it's just it's an additional step that allows us to be more action oriented instead of So we're trying to ensure that everyone's needs can be met. But yeah, I hear you. It does sound a lot like 911, but it is different because it's not quick. We're not trying to get people in and out. We're still making sure we're taking the time to try to resolve the crisis at the 988 level, which if you recall that slide from Arizona, I think it said 80% of those who reach out to the crisis line had their crises resolved there. And if they weren't, then they dispatched the mobile crisis team. So kind of a similar idea.
Somebody else says.
Yeah, I just wanted to piggyback on what Jen said, just in terms of, right, that kind of back to the sustainable funding piece, right? That we can, by doing prevention stuff like transformation ministries and connectivity change and voice group, like there's so many ways, and it's like feels impossible for, you know what I mean? Like it's impossible for mental health in general, not impossible. I appreciate that very much. But are there ways in terms of advocacy, be able to say that like we can look at attributable risk, right, in terms of the percentage of crises that could be totally avoided if we just supported like a revolution of kindness and presence with each other, right?
Yep.
And so in terms of thank you very much for raising that, Jen. And then are there suggestions maybe for Faith Indiana or something about how to advocate for like the prevention, right? Because emergency systems we know are all very, very costly across, right? And like not only just financially, but like human communities and families. And so how do we take that knowledge base and mobilize it to support all of the ways that we know can take better care of humans and prevent a crisis?
Yeah, it's perfect. I mean, what's the most important thing besides responding to a crisis is avoiding one altogether, right? So our state suicide prevention planning back in January 2021, we changed the vision from, trying to achieve zero suicides to the idea that we're going to reduce suicides if we focus on improving quality of life. Essentially, we need to get a handle on what is driving people to think about suicide, even overdoses, and really get into those factors. So social determinants of health is one example. So that's what I'm hearing is upstream prevention. And I can tell you, at least on our team, we're trying to look at how do we encourage upstream prevention. And so we're currently in the planning stages of re-looking at our infrastructure for suicide prevention across the state. I don't know if the suicide prevention coalitions are aware of this. We want them to have a voice in how this is set up later, because I agree with you. This is exciting, but we can do more before the crisis, and we need to. So I just want you to hear, we hear you loud and clear, and that's something we're thinking about. We're always open to your advice and guidance if you see a way that we can do that better at the state level.
Question. Yes.
I kind of get forgot my question, but I do answer part of those. So my question is for 90 days. The movie crisis team have access to rural areas.
Do they have access to rural areas? Yeah, we have community mental health centers like Fort County who are serving rural areas, but it's not everywhere yet. Chris.
My second is what looks like for the Spanish community. Somebody in that movie crisis team is pushing on this right. Since the Spanish community is growing in Indiana, so I believe we have to.
Yeah, absolutely. I will say we do not have a member on the mobile crisis team that is a Spanish speaker, but it is something that I'm looking at when we're hiring. That's something we're looking for bilingual candidates for employment. It's something that we do need to address because we do want to meet the need of the diverse community that we have, and that is one of those needs. So again, right now, I don't have anybody that, speaks Spanish and would be, able to communicate with individuals, but, it's something we are looking for.
Statewide, we have a 988 equity committee, and we have a consultant who's going to be convening focus groups once we hire someone to help her, support her in that. And so if you're interested in being part of that, because there's a lot of needs in terms of equity that we have to address. And I think with workforce and all the challenges we're facing, we need all the bright minds we can get to really think about how we can do that. So if you want to be a part of that discussion to help with that, let me know.
Yes, so I just wanted to touch on, you had mentioned the prevention piece, right? The dealing and working with their social determinants of health. So from a community health worker's point of view, where social determinants of health is what I do on a day, right? I work with the shelter, the lack of home, the lack of income. What does it look like? Or what are your thoughts on a partnership or like a collaboration? Again, like we talked, it's a lot of competition instead of collaboration. So what does it look like with having resources, or maybe somebody that calls it simply, I am here with these thoughts because I don't have a shelter, because I don't have a house, or because I don't have food. Like, so what is a partnership with those of us that are community health workers that are working with social determinants of health with our patients? What does that look like? Is that an idea? Is that, you know what I mean? Like, or if it's not, how can we make it one?
Yeah, I mean, right now we're focused on just the basic infrastructure of this system, but that's an extremely important question because we know that like we can't have a one size fits all. We have to meet people where they are, and it may be a housing crisis led me to be in crisis, and I need housing resources. Right. So what I really want to know is if we can utilize the software, that I touched on with the 988 centers, not just linked with the crisis stabilization units and the mobile crisis teams, but other resources in the community that provide those services that we can even see, do they have access? Can we connect? But the key is going to be what you said earlier in your comment and your question was, how do we do this collaboratively? Right? Because this is never going to work if we don't all put egos aside and get on the same page as a community and as a state. I don't know, maybe I'm wrong about that, but I hear you about the competition. But how can we be collaborators? So I don't know the answer, but we are very interested in exploring it. If you want to have a discussion, we're just finding there's a million questions to answer. And so we're focused on the basics right now, but we want to hear all this feedback. And if that's also part of the equity discussion, let's have it.
Well, it's also the same with like the mobile crisis, like having that referral system. Like if you guys meet somebody, where they're at, and now we find out that maybe they're on that ledge because they haven't eaten in 3 days and they don't know where they're going to get their next meal, or they don't have a roof over their head, or their lights just got turned off. My idea is building to find a referral. Like, how can we work together to
absolutely and collaborating.
Yeah.
Again, collaborating is key. And I will say, at least for our mobile crisis team, something that we developed and put together that everybody on the team has, it's a community resource sort of guide that has clothing pantries, food pantries, shelter location, treatment. It's not all encompassing. We're never going to be able to gather everything, but it's pretty inclusive. It's got a lot of things in there. So we are able to get people connected to those, and that is something that we do a lot of work already. So we were familiar with that, but yeah, collaborating as a community when these needs come up is key.
Okay, I feel like we can have one more question, and then I want to bring up Rebekah Go and thank you, the three of you. So we'll do one final question. The person in the back with the black sweater.
So one of the things that often comes up, actually doesn't come up when we're discussing mental health, is individuals with dual diagnoses, intellectual and physical disabilities. And that is a really big area of opportunity in both St. Joe and Elkhart County. So the question is, in crisis response teams, are they trained in or have experience or tools for working with those individuals that, sometimes the behaviors
We know that it's a need, definitely know that's a need, and we're taking those active steps, to be able to meet that.
We're also collaborating with the Division of Disability and Rehabilitative Services to try to figure out how we can be partners at the state level, you know, and really look at some of the issues and barriers that exist. Is there anything we can do to, I guess, ease or break down those barriers for crisis response?
Okay, so thank you so much to the three of you. The work that you're doing is incredibly important. So we thank you for being here today and talking with us about it. I would like to bring Rebekah Go up, and I know people are probably going to have questions for the three of you. So if you don't mind, if Rebekah can do her presentation before you leave, because I think people will probably want to stop you on the way out. So you okay with that? So Rebekah, you have been referenced multiple times. Rebekah is director of the Office for Common Good at St. Mary's College. Today she's speaking with us because of her role with the Jail Diversion Group for Faith in Indiana. And Faith in Indiana has been doing an incredible job with organizing and trying to direct a lot of the community's efforts toward what can we do collectively to advocate for support, financial support for all of the services that were just talked about. So I'm going to step away and let you.
Hi, yeah, my name is Rebekah Go, and I work at St. Mary's College. First of all, I didn't create a presentation because I didn't exactly know what was coming before me. I didn't want to repeat it, so I don't have any slides or anything. It's just me. Sorry. I just want to say real quick. Oh, sorry. Really thank you. You guys are the ones on the front lines, right? You're the ones actually meeting with clients and kids and mothers and people who are struggling. I'm not one of those people who actually has the personality where I could do that for a living, to be absolutely honest. And I'm just grateful that folks like you exist and are willing to do that. And usually are doing it at a rate at which you're not compensated probably as much as you should be. I'm coming here as just Rebekah who has had some personal experience with mental health and the intersection of incarceration. I am just a mom with 2 kids, and at one point I was married. And in 2016, my husband had an acute psychotic episode that honestly we just didn't know what was going on. And in the middle of the night, about 2:30, I found him in the basement pacing, talking to himself, smelling of alcohol and having a gun. And I was terrified, as you can imagine. My kids were on the 2nd floor, he was in the basement. And he was very, very ill. And so I asked him, I did the only thing I thought would make sense. I said, why don't you just lay down? Why don't you just sleep? Like, we can talk about this in the morning. And he flew out into the night with a gun and got in his car and drove away. And as you can imagine, I was scared for him and I was scared for what was going to happen. So I called police and they found him and they asked me to come to the site and try and talk with them about what to do. And they said, did he say he was going to kill himself? And I was like, well, no, he didn't use those words, I'm going to kill myself. But he said his life was meaningless and everything. And I said, look, he sent me a text message, he's got a skull and the bones. I think this is a sign. And they said, well, that's not enough. And so they arrested him. And that was appropriate, given the resources we had in 2016. And it kept him safe and it kept me and the kids safe. But what it really did was it just delayed treatment. He didn't get the help he needed. And it made him really, really angry at me because I called the police. And ultimately it left him with a record and parole and a lot of other consequences that were unintended. So a couple of years ago, I told that story to Andre Stoner, who's the sole employee of Faith in Indiana in South Bend. And I said, what are y'all doing about this? And he said, well, how would you like to help us? Darn it, I hate that. So I started going to meetings, mostly on Zoom. And I was going to these TIROS meetings, Trauma-Informed Response-Oriented System of Care. And we were looking at different models. And we had a meeting with this really smart lady from Tucson, Arizona, who said, we're doing this particular model here. Her name is Margie Balfour, and they exactly do what now the state of Indiana wants to do, but this was in 2021. And so I of course am just like a person who has no background in this, but just started asking questions like, oh, well, what, can we do that here? Why not? What do you mean we don't have the money? What do you mean like people don't want to do this? What do you mean? You know, and that's just like my personality, it's the way I learned. And with Faith in Indiana, it was what we needed. And we all started asking these questions. Well, what do you mean? Why not? We don't have a system, we don't have the funding. Well, why not? Well, who do we need to talk to? Why not? And we found out, oh, we're getting like $60 million in ARP money, American Rescue Plan money. Why don't we get some of that? Do this. So we had this big meeting in May of 2021. We got these important people to come and we said, stand in front of all these 350 so people or 300 people and tell them you're not going to fund something like this. What do you think? And strangely enough, they were like, oh yeah, we're going to fund this. In fact, this is a fantastic idea. It's my idea. Can I tell you that? No, that's not exactly what happened. But basically they were like, yes. And so we got the county to say, we're going to put $2.7 million into establishing a behavioral crisis center. And that we've continued to have these kinds of conversations, kind of the why not, and the what about, and the like, you know, what are the barriers and how do we get there? And I'm not really good at hearing no, so that's kind of what happens. So I'm sit on the, and I think it's a really important thing I should say. I think it's really important that people like you and like me are at these meetings, because I do think there's sort of a blind spot. Because once you're in the system, you kind of have a reason to sort of like, you tighten up, you're like, you don't want the outside people picking at you, you know? And I try not to be mean about it or rude, but I do tend to be a picker. Like, but that doesn't make sense to me. Explain that to me again. Explain that to me again. So I happen to sit now, unfortunately, on the Behavioral Crisis Response Center, the advisory committee, and I've gotten in trouble, like not in a pleasant way, but like with the head of some organizations when I say like, you know, looking at when they draw out where everybody's gonna sit and everything, I said, oh, so if I brought my husband here, then I would sit here? And they're like, well, no, you wouldn't be there. And I'm like, so you want me to bring my husband who's having a psychotic episode, and you want me to just drop him off and pick him up in 23 hours? Really? Like, that doesn't sound like that's something I feel comfortable. And so we talk about it. And then I go later and I talk to somebody else and I said, was that the wrong thing to say? And they said, before you said it, nobody had used the word family in these meetings at all. Because they're thinking from the way they think, which is not a bad thing. It's just like the role of the Rebekahs and things is to be the one who says, but what about? And so that's what I've been doing. From the state side, so we got the 2.7 million to say we need a behavioral crisis center in South Bend. And we had been in enough conversations with Oaklawn to know that they were rolling out a crisis response center. But I'm a system thinker, it's the way I am. And I was like, but that's just a one-time deal. We're hopefully never having another pandemic, so we don't want American Rescue Plan money again. So where are we going to get the money to keep things going? So then we started having more meetings. I swear I spent a lot of time on Zoom. And we found out about the 988 rollout. And we found out that there was a bill in the House and the Senate a year ago, or maybe now 2 years, Bill 1468, which established an ability in the state of Indiana to capture money from 988 to like a surcharge that could then be used to fund the ongoing care and ongoing treatment of a complete like system, and not just a system that means that you have to live in St. Joe County, but a system for the whole state of Indiana. Someplace to call, someplace to, or somebody to come, someplace to go. That's what we need, right? So of course we start saying, well, why not? Why not? Why wouldn't we do that? And so we had a big meeting last day, I guess it was, in a church, Berean, I know the Berean Seventh-day Adventist Church. We brought some other important people and said, why not? And Linda Rogers, who's a state senator from near like the Granger area, was like, yeah, you're right. Why not? And Chris Drapeau said, yeah, why not? And other people, what's her name? Bauer, who's a state, Maureen Bauer, she was like, yeah. And then, but the thing we keep hearing is, nobody wants a tax. Nobody wants a tax. Well, first of all, we call it a surcharge. That's clear. But then we start breaking it down. We're talking about $1 a month per plan. So if I have 3 phones in my family, because my kids each have one, $1 a month, 3 cents a day to support an entire system that will generate revenue, $90 billion a year to finance a system. When we start saying, really, nobody wants a tax, but are people willing to have a surcharge? And so then we start having conversations with Senator Mike Crider and Senator Ryan Mishler, and we start poking a little bit more. Why not? And that's basically where we are. And so I would invite you to come be like us, poke, prod, say why not. It really bothers me when our senators and our House representatives say, my people don't want taxes. Like, talk to your people. Have you heard their stories? My story is not unique by a long shot. There are so many people, maybe not the severity, maybe not the exact thing, but a lot of people have been affected by mental illness, have been affected by substance use disorder, have been affected in some way or shape or form, and they would be more than happy to give you $1 a month more on the freaking cell phone bills to fund this. So that's where we are. We just had this big assembly last week. I didn't go, thankfully, but and now we're starting to talk some more with our state representatives, with our with business owners. We really need like Salesforce, Cummins, Lilly to say, yeah, they're right. We're starting to talk to other people. We have the Sheriff's Association and the Prosecutors Association saying, yeah, they're right. But we really also need from folks like you to be part of our efforts. So locally, there's 25 churches. If your church, and the list is out in the other room, but if your church isn't part of it, ask them if they want to be. Or if you aren't affiliated with a church, that's fine too. Just join our group and be part of the rise. So thank you.
So there's a question right there, and I think we have like 3 minutes for questions.
So this question is for everyone. Talk about funding. As a group, are you actively involving our U.S. senators and our U.S. representatives from the state to actually vote for things at the federal level that would help fund this stuff? Because we have 2 state senators right now who voted against the American Rescue Plan. We have a majority of our state representatives who voted against the American Rescue Plan, and yet that's what we're using to start this with. And every time funding comes up, because it's not from their party, they make it political and vote against it. This is not a political issue. This is a public health issue. And you should not be in that situation that you were with your husband. Even if it was 2016, that should not have been. And it should not be today. It just angers me when it's made political. We need to be telling, you need to go back to the governor and tell him that, so he can get on pressure those senators.
Well, I can't talk to the senators and representatives, but I can tell you this, the governor, we meet with the governor's office regularly about this. So they are very interested in this 90-day effort succeeding and this crisis system work succeeding. So we do have advocates in the governor's office. I can share that.
Thank you.
And I would say that with Faith in Indiana, we've met with people from both sides of the aisle, and they've been very receptive. But what we find we have to do, and this is not a bad thing, but it's just the reality, is it really involves telling stories, and it really involves them seeing it themselves in the situation and or their constituents in the situation. It's called self-interest. So what is their self-interest? And well, usually it's something close to home, my nephew, my niece, or my neighbor. And when we get to that point, they are usually pretty amenable to the idea, but it is, sometimes it's just getting that first meeting.
Anybody else have a question? Rebekah, thank you so much for the work that you're doing. Everybody's had a good summit. The tables, I think, are going to be out for another 15 minutes, and please do your evaluation. So on the back of the program, there's a QR code, and we'd love to hear feedback from you. Hopefully everybody's had a good day. So thank you.